is a case of a traumatic cataract which presented to us with a vision of hand movements. On examination, there was a thick anterior synechiae between 11 to 12 o'clock position. There was a calcified central plaque and a suspected torn anterior capsule. We had planned for a routine 2.8 mm phaco emulsification with IOL, keeping in mind with possible complications and being ready with vitrectomy and secondary IOL options. A side port was made. The anterior capsule was stained with trypan blue. The anterior chamber was filled with viscoelastic. Using a keratome, a limbal incision was made. A biplanar tunnel was made, and then entry was made into the anterior chamber. Using a dialer, the anterior synechiae was released carefully, making sure that there was no damage to iris or bleeding. Using a cystitome, the capsuloprexis was initiated, trying to avoid the calcified area. Slight difficulties were encountered near the subincisional space, where the entire capsule was fibrotic and attached to the posterior capsule. Now, as you can see, the entire anterior capsule, nucleus, and posterior capsule has become adherent at this point, causing a dehiscence while capsulorhexis. Without further manipulation, Warner's was used to cut the remaining anterior capsule, and the rhexis was completed. A careful hydrodelineation was done just to loosen out the endonucleus. Care was taken not to do it forcefully. Using the Sinski's hook, the nucleus was gently rotated and brought into the anterior chamber. As you can see, the central plaque, which was calcified, is left behind. Phaco emulsification was done slowly and carefully in a carousel method with high vacuum and less phaco energy. Usually, the traumatic cataracts are soft. Viscoelastic was filled into the anterior chamber before removing the phaco probe. As you can see here, lifting the central plaque which is along the rupture in the posterior capsule. As there was no vitreous disturbance, we went ahead with cortical aspiration using the bimanual irrigation and aspiration, carefully stripping the cortex in a circular manner. During this time, the central plaque is acting like a scaffold, not allowing to break the anterior hyaloid face. Keeping the irrigation in place and maintaining the anterior chamber, microforceps was used to make the tear into a primary posterior capsulorhexis. The flap of the posterior capsule is grasped and pulled towards the center to prevent extension of the tear. At the final point, it was very adherent. So using a cystitome, a tear was initiated and the primary posterior capsulorhexis was completed. Here you can see a thick posterior plaque. Since there was no disruption of the anterior hyaloid space, we planned to go ahead with single-piece foldable intraocular lens in the bag. The surgeon himself loaded the IOL in order to avoid any mishaps while injection. The IOL was carefully injected, making sure the leading haptic goes into the bag first. Using a dialer, the second haptic was rotated under the anterior capsule and positioned in place. The remaining viscoelastic was washed from the anterior chamber and the wounds were hydrated. Post-op day 1 showed mild anterior chamber flare with a well-centered IOL and microcystic corneal edema. 1 week post-op, the best-corrected visual acuity was 612 with normal IOP and a happy patient.